right, so the question is, benzalkonium chloride affects the eye by which of the following mechanisms? And we'll see what you guys think. All right, so there's pretty close to a consensus there, but we'll see what Keith has to tell us. Dr. Barton's slides, please.
Thank you very much. Someone's got a sense of humor because I'm primarily a glaucoma surgeon, and this is primarily a surgical condition, and I've been asked to talk about medicine and lasers, patients with corneal disease. I've got some financial disclosures, not specifically related to corneal disease, but everybody knows that the interaction between glaucoma and cornea is complex, and Laura's already alluded to this kind of problem, except my title is a little bit more nebulous because it covers the whole of corneal disease, unfortunately not just eye syndrome. And we know that you can't talk about cornea in medical therapy in glaucoma without talking about the ocular surface. It's all kind of part of the same thing unless we restrict ourselves to corneal transplants. And there's all these factors that I've outlined in the outline, and if we go through them individually with all the evidence, we'll be here for a very long time and no one will be awake. So I'll highlight a couple of them. So there are challenges in measuring the pressure accurately in corneal disease. That's not just after laser refractive surgery, or not just in patients with naturally thin or thick corneas, but also in diseased corneas and many other types of corneal surgery. And this is something we need to think about. There are common conditions like keratoconus. This patient's obviously got quite obvious keratoconus, and the central cornea can be thin, and the pressure can obviously be inaccurate, and we don't always know exactly what it is. And there are other odd corneas still walk through the door. Radial keratotomy is not so common. Does this make any difference to pressure? Well, I don't know at all, but I have to stop and think sometimes. And then sometimes we see funny inlays, and you can probably fit the Goldman in between it, but is the pressure accurate in any way? I don't know. But these are things we've got to think about. And increasingly we see in tertiary referral practice keratoprosthesis, and I just don't know how to measure the pressure at all in these situations. So pressure measurement's a big deal in corneal disease. Already from the question you alluded to the problems of medication, and as a general principle we all know that glaucoma medication exacerbates pre-existing corneal disease. Beta blockers are anesthetic and reduce baseline tear production. They reduce goblet cell density more than pilocarpine or brimonidine. Prostaglandins actually seem to increase goblet cell density in some studies, but in fact are still inflammatory to the ocular surface, as prostaglandins by nature are inflammatory cytokines. The preservatives, obviously, we hear a lot about, and these exacerbate corneal disease. Benzalkonium disrupts the lipid layer of the tear film, reduces goblet cell density, and promotes inflammatory mediators. And if you add the benzalkonium to the effect of the drugs, and we hear a lot about the preservatives, but remember the drugs do this too. You're adding the whole lot together, everything is accentuated. Glaucoma medication itself can cause certain types of ocular surface disease. I used to, not so commonly now, see this. This is a chronic undiagnosed brimonidine allergy where the patient comes with a bad ectropion and someone's trying to fix it, and occasionally they have uveitis from the undiagnosed brimonidine allergy. This is not a preservative problem, this is brimonidine. Very unusual, COSOPT allergy typically causes the eczema of the lower lid. I've never seen this. Did the patient mix up COSOPT with brimonidine? Was this a brimonidine allergy? Or, well, I showed this to Sanjay Asrani. He says, no, it's a timolol allergy, and it's rare, but you get a follicular conjunctivitis. So you can get all sorts of ocular surface problems exacerbated by the medication. And it's popular at Moorfields as a reaction to drug-induced allergy to give the patient preservative-free versions of the same drug, and that does not work. So if you've got a COSOPT allergy, don't give the patient preservative-free COSOPT. This doesn't sound like rocket science, but in fact it is a common practice. I don't know. Anyway, conjunctival cicatrization, less common these days. I mean, is this pemphigoid or is this pseudopemphigoid from chronic glaucoma therapy? You don't see it very often, but we obviously would refer this to the corneal specialist just to clarify. And then, of course, the endothelial cell. Glaucoma surgery can exacerbate corneal endothelial cell loss, as we've heard. High eye pressure damages grafts, and glaucoma is actually the single biggest risk factor for graft failure. So if you've got your PK or your DSEC and you've got glaucoma, that is the single biggest risk factor for failure, and that's been known for a very long time. This is the data from the Australian Graft Registry in 1993. It showed that basically glaucoma causes grafts to fail whether or not the pressure's high, and we tend to be very proactive at Moorfields in surgically controlling glaucoma prior to grafting if the patient's on more than a couple of medications. The corneal surgeons send us the patients for actually tube implantation in advance because it's very hard to get trabeculectomies to survive. Obviously, laser doesn't have a big role in patients with serious corneal disease other than CPC, but early laser can protect the ocular surface and endothelium against all these toxic effects we've heard of. We all know that, and the light trial has been mentioned already today. And the lasers in glaucoma and ocular hypertension trial demonstrated clearly the benefits of SLT over medical therapy in newly diagnosed medication-naive ocular hypertension. And this was, there were 718 patients enrolled, 356 randomized to SLT, 362 to drugs. The primary outcome was actually quality of life, and there was no difference. And one could say that it's because we really don't have good quality of life tools in glaucoma that measure surgical or medication quality of life, but there was no quality of life difference. But it's worth pointing out that at 36 months, 75% of patients were medication-free after SLT. And the light trial repeatability study will be presented on Monday in South 152 at 1424 by Gus Gazzard, the trial chief. So often in corneal disease, you can't really do SLT if you can't see the angle, or if the angle is completely closed, such as in this case of posterior polymorphous dystrophy. So then you're really still stuck with medication or surgery. Glaucoma is profoundly interrelated with corneal and external eye disease. SLT can potentially benefit patients with ocular surface disease if you can actually see the angle and see through the cornea. Light trial obviously doesn't apply to patients with more severe disease, where SLT is unlikely to be logistically possible or effective. And patients with significant corneal disease and high pressures do need good pressure control before endothelial or PKP, and we still tend to do tube surgery, even though we all know that the tube can damage the endothelium, simply because the tube's more robust in terms of long-term pressure control. So thank you for your attention.
That was excellent. Can we have Dr. Barton's ARS question? Thank you. Give everyone a few moments there. All right, great. So next,